We have 10 minutes for questions, so if people could stand up, and I'll take a couple of them at once. But let me ask the first unfair question at the beginning, because this was the question that I got when I presented what I thought CMS should do. They said, don't tell me what I should do, tell me what the plans should not do. What do they, what's a plan should never do this? Or when you developed the plan, what was your biggest mistake in developing it? Raj, I'm sure you didn't make any, but if you did?
No, we don't do that. It's like, I think the biggest mistake was not realizing the importance of governance and leadership. I think we tried to bring everybody in. You know, our size limit was 2,500 aligned customers to a group. And we tried to help people build governance and leadership. And what we found is that it takes too long. They either have it in place or they know how to do it very quickly, but we didn't have the skills to teach governance and leadership to physician groups who just wanted to come together. So those were the first groups that we found were not very successful.
We were probably a little too generous and allowed some of our second wave groups to come in when they really didn't have the capacity to come in, or when they had stated willingness but really didn't have willingness.
This may be kind of a minor point, but in terms of just coming up with a knowledge management system for the technical assistance and the shared learning, I mean, things were just being thrown up on a web page and no one could find or access anything. There's just a lot of information overload between the data reporting, the TA provision, and I think we probably need industrial designers and communications people on a lot of these interventions to make things user-friendly and easy to find what you need.
Joanne?
Hi, Joanne Lynn from Longterm Institute Center for Elder Care. I wanted you to reflect on these kind of linked issues. One is what to do about long-term services and supports. You know, the boundary between the medical care and housing, food, transportation, caregiver support is quite blurry, especially around SNFs and kind of post-hospital care. But none of you have really mentioned dealing with that. A second is there's this population of people who are very difficult to move around and really need to be seen at home. Shouldn't we be thinking in terms of geographic service provision rather than just whoever the person happened to sign up with? If you're sending a doctor, a nurse, or anybody else down a road and there are 12 people, let's not send 6 different services. Let's send one service that sees all 12 people. At least when I was working in DC, that would have cut half of the costs of Medicaid home care. But we aren't willing to think in terms of geographic service provision. A third issue that's kind of linked to those is who should get the savings. It seems that there's this assumption that the savings should go back to the kind of professional providers largely, or to the shareholders in the company. But shouldn't a lot of this go back to the communities involved? Because the really crying need is so much for those supportive services and the services that are right now so heavily underfunded. If that's the case, then some of this should be organized in a community-anchored way, so that what Annapolis saves comes back to Annapolis, or at least part of it comes back to Annapolis. And there's a sort of civic pride involved, which also allows the geographic distribution, rather than sort of whoever they happen to sign up with as their health insurance provider, or whatever the narrow network was that got them into a particular doctor. It seems that once you're sick enough to really need a lot of care at home, then some of the routine assumptions kind of get turned on their head. What do you think?
Any thoughts?
Well, in terms of plowing savings back into communities, it's an interesting question. I always think if we could actually generate savings, then we all pay premiums and co-pays. Why not give it back to the people? So in terms of geographic service provision, Vermont is doing some really interesting work with wraparound services that are community organized and provided because there are lots of small independent practices. So I think that's something to think about. If you set the payments right, at least in, it'd be more difficult in rural areas, but if you set the payments right, then providers will find a way to go to the home.
Yeah, I think in terms of savings coming back, at least from our perspective, it goes to affordability. The savings are shared both with the providers and back to the employers. The employers eventually will result in improved affordability. I mean, that's the long-term goal, is to improve affordability, part of it. Really as a company, we kind of drive a lot of the geographic questions and things like that back to the providers. It really is a local business. It's really hard to, sitting in Connecticut, to dictate what happens in Texas. So.
When you say providers, you mean hospitals and doctors. And when
Right,
I say providers, I include Meals on Wheels.
Great.
So Joanne, I think what I would say is we can look in the United States, but we really got to look overseas on this. Because if you think about it, we spend substantially more than any other country on health care. We spend substantially less than any other country on social services. And so all these other countries are doing both of them quite reasonably well, and we are stuck with our healthcare financing model, and that really limits what we can do.
Hi, John O'Brien from CareFirst Blue Cross Blue Shield, and Debbie, thanks so much for being here. I wish I would have brought my copy of the CPCI evaluation so I could get an autographed copy of it. But I was particularly interested in the regional challenges in doing sort of multi-payer quality reports to drive the discussions among the physicians, as well as the challenges that the practices had in doing risk stratification. And I just wonder if there's been any progress made or any backstory that you can share that maybe didn't appear in the report, or just any advice for the room.
Sure. So in some regions, there could be 9 or 10 payers participating. In a place like New Jersey, it's fewer insurers, there's more market consolidation. So everyone agreed that it would be good to at least align the reports in terms of the same format, the same outcomes, and preferably to actually have an all-payer database where they gave them one report back. Now, it's been very difficult to get that off the ground for a time-limited demo, but some of the regions have been successful in doing it. I think they sort of piggybacked on other initiatives where they were doing health information exchange or focused on this. So I think at this point, maybe all but one region is either doing aligned reporting or moving towards one report. So I think they have made progress, but it's been really hard. And there's also been issues with the federal procurement for them to go in. They can't just, it's been very difficult to figure out a way to have a competitive bid when they have to coordinate with the private payers, right? I mean, which we understand why there are rules against sole sourcing, but in this case, it makes it very difficult for the federal government to go along with what the group decides is the right decision. And I think they've figured out a way to do that, but it's taken a while to work around that.
Thank you.
So I think I heard a couple of different messages on this panel, but among other things, I started out with this study showing that only 50% had advanced one of the three triple aims, so it's really not doing well. Don Furman was talking about some of the stuff, I think it was 23 years ago, he had started and sort of been pushing the same battle on things that actually do work. Deborah, you mentioned it's really hard to figure out what is working and what isn't, and then even the stuff you do know that works, you might need like an industrial engineer to help get it communicated well so others can implement it. And of course, we're sitting in the Institute of Medicine that was involved with figuring out close to 17 years ago that it takes 17 years for lessons to go from bench to bedside. I mean, what can we do to speed this up? Because I think that's factoring in also to why we're wasting more than some countries spend on health, and so it's all, the lag is what's causing a lot of that. So how do we get how do we figure out the good stuff and get it sped up quicker? That's not an easy question, but
I think that's what you're interested in, right?
I think there are two answers, two probable solutions to speeding things up. One is really a recognition that is that different models will have to work in different areas. The ACO model can't work everywhere. Bundled isn't going to work everywhere. And so innovation in alternative payment models and HHS's new announcement is driving a lot of change. Even within our company, in a month or so, we're driving a lot of change. The second is really, are the ONC folks still around? Or do they call it happy hour already? Okay, great. So really, ONC's new drive of interoperability will help a lot. The question is going to be, how do we get physicians who we already asked to spend hundreds of thousands of dollars on EMR systems, they adopted it, but now we're going to ask the vendors to fix the interoperability problem. I don't know where that money is going to come from. I don't see it coming from the providers saying, oh yeah, sink in another more. So my idea to ONC is we need another $44,000 per provider.
Always more.
That will speed this thing
We
up.
need more money from Cigna, too. Last two questions, because I think I'm going to be the one answering all of them pretty soon.
That or happy hour is calling loudly.
Yes.
Bruce Sigsbee, Academy of Neurology. I'm listening to this, and I think there's one aspect that we really haven't talked about, and at least in my specialty society, and I know a number of others, we've had these kinds of conversations about quality, the cost of care, have wrestled with how do we help with our membership and really move in this direction and help them adapt to change. And one of the aspects that I don't know how much you know about is most specialty societies are at some point or another in developing a clinical quality data registry, which can both have relevant quality measures for your practice. And right now, I'm on an Epic system, and I have to do the basic primary care stuff on people even I do a procedure on. It has no relevance to the care that I'm delivering to that patient, and this will move in that direction. It will accelerate the adoption of new care by the measures that you choose. And one of our early cross-cutting measures is going to be improving the coordination of care with the primary care physician. So I think that is at least a force that could be harnessed for some of these kinds of issues. And I think we're all struggling with how do we evolve the healthcare delivery system. And as you move forward with this effort, maybe considering some sort of partnership with the specialty societies, they really do want to make this better. And yes, there are people who are resistant to change, but I don't think the organizations nationally really represent that group. And just as a suggestion.
It's a great suggestion.
Very, very quickly, Bill Hogan with Bipartisan Policy Center asked Deborah, you said there was a 20% financial incentive that you evaluated in terms of these programs. I haven't heard the return on, did you do an ROI on these plans?
That's a good question. So the Comprehensive Primary Care Initiative has only been running for, well, now it's almost 2 years, but we only have 1 year of impact data on it. So the first year we didn't really expect them to be able to transform. They actually looks like they're cost neutral, which is pretty good for, at least for the Medicare fee-for-service beneficiaries. So everyone would like to generate savings, but no one was expecting, most people would say total cost would increase the first year is what we would expect. So stay tuned.
I know you said that no one else could speak.
I always listen to her, so I have to listen to her.
No, you don't. Melinda Abrams, Commonwealth Fund. So thank you all for your stamina. But I'm sitting here and I'm like, oh my goodness, everyone's going to walk out of this room and all they're going to remember is that Jerry said 50% of the programs don't, only one of them meet the triple aim and half of them are in existence years later. And Debbie says, oh, when you look at the Medicare care coordination demonstration, only one of them was successful and years later it didn't exist. So I guess I find that so, and yet we also start the day by saying, we know there's some really promising programs. So how do we reconcile this? And so maybe it's that we're not academics and you are. Maybe it's the standard that you use and that you're always looking for certain kinds of significant tests. But I'm also remembering, but I've read these studies. I look at these studies and a number of them are really promising. A number of them have comparison groups. A number of them are looking over time, pre and post, and adjusting for a number of things. So we're not making this up. And I'm sorry, I swear I'm going to close, but Debbie, you were a co-author on a study that was a follow-on to the Medicare Care Coordination demonstration that appeared in Health Affairs. It's one of my favorites because it was a bunch of studies that actually had either negative or null findings, and then you dug a little deeper. Randy Brown was the lead author, and you said, here are 6 elements that we think are associated with successful Medicare Care Coordination programs. And a number of those, I'm not going to list them, but I think there's also a way of looking at what all the preponderance, the plethora of information that we do have, and kind of saying, how can we build something that is successful, and that building on a number of kernels and gems and pockets of innovation that are occurring across the country. Chad Bolt did a similar paper. Karen Davis did a similar paper that came out recently. So I just don't want us all concluding and leaving this day thinking there are no models out there, there are no successful programs. There really is a lot on which to build.
That's a good point, Melinda. And I think, there were 2 papers in that Health Affairs issue. Both showed that the successful elements of a model with the right targeting can be incredibly successful. The other one was on Washington University, who changed their care coordination program and ended up generating savings. These programs, it's like you have to find the right program, and then you have to have money.
I'm not saying that we have always the right environmental pieces. I guess
Right.
It's just more that it's more than just tea leaf reading. There's experience.
Right.
And
No, they're
data,
definitely.
And data.
And I think, one of the things is, before CMMI, which is now very focused on spread, who was going to fund these things? A lot of foundations come in, they want to say, let's do something innovative. And then what?
I know, we're so to blame. I know.
No, but it's like, is the government going to pick it up? Is it a commercial insurer going to pick it up? Why? There's this gap, and there have been successful programs. They're case studies, though, right? And to move from the case to testing, ideally, you would think from an evaluator perspective, you find something that works, you distill the key features, you do the lessons. Why didn't someone after Medicare Coordinated Care demo say, okay, we learned these 6 elements, let's do it in, pick some new areas, some new leaders, some new programs, make it a little bigger, refine it a little more, eventually go to scale. That step doesn't happen.
Well, it's also just such a crazy method. All of manufacturing works on time series with control charts. And we throw them all away. We want this P of 0.05. And if instead you said, okay, we're going to take Cincinnati and we're going to figure out how to make Cincinnati really good, you're not going to think about randomizing Cincinnati. You're going to make sure that 20 things that you're measuring get better over time.
Well, there are smart ways to do it. Raj is building in this test. Is it is it a clinical predictor or some sort of algorithm, or is it the care coordinator or physician or staff's judgment? There are ways to build in tests to refine these things quickly if you really focus on doing it. There's orthogonal design where you can
Hold
say.
on, I'm getting the message that we're doing a great job, but we now need to wrap it up.
Wrap it up.
Exactly. So-